the reality is there's never a point in anybody's life where you wouldn't want a delay in an ability to preserve beta cell function. So you talk to anybody who's lived with or parented a child with type 1, and they will always say, if I could have only had 2 more years here, whether it was preschool to kindergarten or first grade to being a slightly older child who has some executive function, or like Dr. Putman said, a young adult who has a fully formed brain and might be able to manage their diabetes a little bit more successfully by getting through those periods. So, but it's a big paradigm shift, right? Like we've for 100+ years now managed diabetes by giving insulin as our only tool effectively. And we've gotten really good at giving it and measuring glucose much more accurately and providing improved life because of those incredible technological improvements. But we haven't before had disease modifying therapies meaningfully, and that materially changes the whole discussion about screening in a way that I think makes sense for both patients and families, providers, and even payers, right? Certainly we can screen and prevent DKA, and that has huge cost savings. Single DKA admission at diagnosis is somewhere between $75,000 and $100,000. I've certainly seen plenty of young adults who get misdiagnosed, pointed out, and even though they should have ended up in Dr. Putman's clinic, are managed by a primary care doctor until they end up in DKA because they got put on an oral. That all could have been prevented with significant healthcare savings by way of screening and monitoring. And then when you layer on top of that the potential to preserve beta cell function for longer by way of offering screening and identifying people, I think we really are starting to talk about changing the trajectory of the disease, not just doing better at managing the disease with insulin and glucose monitoring. So it'll take time for that to go through, like all new things do. There's always huge therapeutic inertia, especially when these disease-modifying therapies that we have available now are cumbersome and incredibly expensive. But that will hopefully over time change too, and I think those things will start to change the conversation about how and why we would screen, and hopefully get us to a point where everybody has the opportunity to be picked up before they have clinical diabetes. Even if disease-modifying therapy may not be the thing that is right for them, it should be able to improve our ability to deliver healthcare to the larger population living with type 1.